Welcome to the Talking HealthTech podcast. My name is Peter Birch, and in this episode, we're kicking off a short series of conversations that we're hosting to really get a better understanding of the role of technology and standards and infrastructure and how they're going to power connected care in Australia. And today, we're really setting that scene and taking some lessons from around the world and how to apply them in our local landscape. I'm joined today on the podcast by Farhoud Salimi, Chief Technical Officer at Telstra Health, by James Agnew, Chief Technical Officer for Smile Digital Health, and Angie Bass, Executive Vice President for Velatura Public Benefit Corporation. G'day everyone, how are you going?
Hey Pete.
Doing well, thank you.
It's great to have you here at a mutually inconvenient hour, as it always is when you do a global call from Australia. So appreciate your time to dive into this important conversation. And we've got some really interesting perspectives from different parts of the globe, but also from different parts of how we do healthcare in different parts. So I want to kick off firstly, Farhoud, from your perspective, you know, this topic of connected care and how we bring together different parts of the ecosystem. Sometimes it can be a bit of a nebulous topic. So it'd be great to get your kind of scene setter here on what are we actually talking about when we say the connected care ecosystem? What are the challenges that healthcare organisations face when they're trying to build it, I guess?
Thanks, Pete. Look, I'll try to give you my definition of that whole nebulous connected care vision, I guess, that we have in Telstra Health and how we sort of approach it. For me, I think there's a couple of things that I can touch on that brings that to life. One is that our information or patient information can seamlessly flow through the different care settings from different providers and different settings, and you can get access to that. And clinicians can get access to that data in a real-time sense, obviously in a secure way, in a secure and safe, clinically safe way, but they can get access to it across those different settings. And it is actually continuous regardless of where we receive care. And then obviously from a technical perspective, it would be nice that if all of our digital solutions actually worked well together in a seamless and harmonious way using those standards, and then ultimately leading to better patient outcomes because we have better access to better information at the point of care. So that's what I think is the definition of connected care, if I were to boil it down, having the right level of data available to you at the right time, at the right place to be able to provide care back to the patient. Now, I guess if you look at the challenges in our ecosystem and why it's so difficult to, I guess, get there, I sort of break it down into three subsections, if I can. Obviously, the technology side of things, historically, we've had our data in silos through different systems. And that's not just the technical silos, but also organizational silos around that stop the sharing from happening. Secondly, we haven't had real interoperability standards and how we collect the data, how we store it, and how we share it. So when you try to do that after the fact, it becomes very, very difficult to then try to connect multiple systems together when they're actually storing data in different ways. So that interoperability is actually more than integration. It's how you actually do the definitional side. But and then when you put all these big new systems in, as I've done in the past in our public health systems, you focus so much on putting that system in for that use case, you forget about integrating it, or you run out of money when you want to integrate it, and it's always a second order task. And then by the time you get there, you've ran out of cash, and then you can't replace it with a new one, right? So once you get the data out of the silos, get it standardized and formatted the right way, then actually making sure you're focusing on the integration at the right points is key. So they're the technical challenges I see. Then there is some of the privacy, security and compliance regulatory factors. So the balance between securing health data and then having it available at the right time, at the right place, and how do you balance that security versus availability? Then obviously regulatory compliance in all the different jurisdictions. And I'm sure James and Angie will tell you the differences between what it's like in the US versus here versus what we see in the UK. Obviously with GDPR and the like, they're all different. So actually understanding the regulatory aspects as well as the security aspects to enable that data to flow is the second part. And finally, I think it's the change and engagement aspect. So as we're trying to move from the paper-based system to the digital system, you need to be able to engage and train not only the clinicians but the patients to be able to be more proficient in the new workflows, to be able to put the right data in the right place, but also engage with their own healthcare record or their own healthcare journey to be able to then utilize that. I think if you get all those three things right, all those three components right within the broader setting with the standards, I think that's where you'll start to obviously address it. So it's not a single problem, Pete. I think it's multiple issues that we need to sort of address at a more of a strategic landscape.
Yeah, no, look, and it's interesting too, if someone was coming into healthcare and you said, oh, it's a technical challenge, it's kind of like all the technology's there. If we could start from scratch and build something from the ground up, of course the technology will make data seamlessly flow in between things, but you unpack some really important points that fall under that technical aspect there. And then we've got all the tricky bits that exist in healthcare, because we've got data that's super sensitive that can't just free flow anywhere. There's that regulatory piece that you pointed out, but also that other element that a lot of people overlook, which is the cultural, the human, the squishy bits that mean that just because it can be done this way, we've got pre-established workflows. This is how we do things, and our system is a little bit unique, so we don't quite fit in this box. So we can't really just start again, because there's healthcare to be delivered every day, and we've got all this existing infrastructure that's there. How do we? It'd be nice if we could make the best of what we've got and then build on top of that, and kind of leverage, a lot of the mileage we've already got to this point, and noting all the legacy of there's paper and there's things that don't connect to each other. How do we kind of bridge from, I guess, our existing situation to that utopia perspective of everything swims together?
I would love to have that magic wand as a technologist, Pete, just to wipe the slate clear and put all the new tech and it all works, right? But that's not reality. We all have obviously a legacy that we have in all of our systems. Look, even in Telstra Health, we have a pretty broad footprint, as you're aware, in primary care, aged care, and even in our acute products. And they're all of our products are from different eras and different technologies as well. So making them talk, we have the same problem, as do most big health systems. So the approach, and look, I could probably talk to you about, health information exchanges, data fabrics, and API first strategies, and, bore you to death. But let me talk to you about how we're doing it, or the approach we're taking within Telstra Health in leveraging some of our current platforms that we have and how we're looking to modernise in steps. So we've partnered with Smile Digital Health. We use their HIE/CDR or data fabric, and I'm sure James will talk a little bit about that. But essentially, we're using it in three forms. So as a fire facade, so essentially we've put the platform, and a couple of years ago we started this journey. So we use the platform in front of some of our older products, so classic products, to essentially be able to create a modern API, Smart on Fire API landscape. And I think we launched that a couple of months ago, which is our Smart API Plus framework, which sits in front of our primary care products, that enables us to translate our old data in the way it's stored into a Fire payload, which then enables our partners to integrate with that in a seamless way. So we have the Fire facade, which sits alongside your older products and helps you have a modern feel or a modern look and feel to it when you're integrating or interoperating. The second approach we're taking, again, using the Smile platform, is we're using it as a clinical data repository or a data fabric. So we refer to it as our Health Cloud offering, where we've enabled the Smile platform to be a data store in the middle, and we're actually pushing all our integrations from all our other products through that landscape or through that layer, which allows it to essentially act as a real-time layer for our analytics and data exchange platform. So as an example, the aged care transfer upload that we have to do to My Health Record later this year, we'll do that directly, but also push it through the data fabric. So we start building that repository. Pathology and radiology referrals, we're starting to push through that framework as well. So over time, we start building this layer out that enables us to have richer and richer data sets in that clinical data repository, that then enables us to have a lot more data sharing and also analytics running on top of it. And finally, the big one is when you start to modernize platforms and build them in a Fire native way. So our virtual health platform, which we launched last year, is actually built on top of the Smile CDR platform. So it's native from the ground up. So essentially, as we're modernizing our offerings and solutions, we're actually looking at a Fire native or Fire from the start approach. So essentially, out of the box, it's interoperable and it can integrate a lot easier with other Fire-based or HL7 Fire-based platforms and systems. So essentially, rather than throwing everything away, Pete, and starting from scratch, you have to have a multifaceted or multi-pronged approach, and from a facade to a clinical data repository to then actually re-platforming with those modern standards, I think is the best way to go.
Yeah, and look, I think about it, it makes no economic sense, both in terms of time and money, if everyone looking to solve these problems were to build this kind of capability from scratch. It's just not feasible, and that's what this podcast is all about, bringing together different parts of the ecosystem, encouraging collaboration so that then with those that do their things really well can focus on the things they do really well, and you bring those parts together, and that's where you get the synergies and some really cool solutions that can solve some big problems. I should call out now that if someone was from outside of the healthcare system and heard us talking about setting fabric on fire and shooting it to the cloud and using a lot of acronyms, the Talking HealthTech glossary is a rich resource of information that has a lot of these terms in there, and I'm sure that my next question to James is going to give the glossary a workout with a lot of acronyms, because we've heard CDRs and HIEs and FIRE and HL7, and we love our acronyms in health informatics and in healthcare. But when we specifically focusing on HIEs for a second, health information exchanges, James, they're sounds like they're a really important part of doing this connecting of healthcare information. What does that actually look like though in the real world? Because we talk about it, but like what's the tangible thing, and or how are they helping clients actually aggregate some of this information and move data around in real time?
Yeah, thank you, T. I love that. Thinking about what an HIE is, the place I always like to start is sort of thinking about the arc that digital technologies often go through when they're being adopted by the healthcare system and sort of being brought forward, innovated, being iterated on, all that good stuff. The first version of any new technology we roll out tends to try its hardest to sort of be an analog of the physical processes that it's setting out to replace. In the case of an HIE, you think about what we're trying to replace. And ultimately, what is that? It's faxes and phone calls. Like, we're trying to sort of replicate the old world where we're, physically moving papers around however we could do it. The thing that we're trying to do with modern HIE, and ultimately the thing that the pioneers that are sort of that are building these modern HIE systems are realizing, is that the next generation of a health information exchange is not just a replacement for faxes and phone calls. It's a network of structured data that's intelligently moving around data. It's gathering data, it's ingesting it, it's uplifting it, it's making it come alive. Ultimately, it's sort of gathering signals from that data and making those signals useful. So it's solving all of these problems, not just making data available at the point of care, which was the original purpose for doing all of this, but ultimately making that data useful for, just a broad range of other applications. I could sort of spend hours talking about the innovations you can build on top of a modern platform for HIEs, but I think what I'll do is I want to talk about two that are sort of really near and dear to my heart. The first one is, I'll throw another TLA at you, another three-letter acronym, which is CQL, the Clinical Quality Language. There's an amazing community that sort of has almost sprung out of the original FIRE community. FIRE itself is just this broad community that has sprung out all kinds of fascinating side projects and other sort of related technologies that work well with FIRE and oftentimes without FIRE. CQL is one of them, and CQL sort of has its origins in quality reporting. The Q in CQL actually stands for quality. But I think the use cases for CQL have ultimately grown way beyond the original quality use case. A specific use case I find fascinating is that of clinical practice guidelines, CPGs. There's yet another TLA for us to throw into the list. These days we live in this amazing information age where the entire circle of clinical care sort of feeding into outcomes, which feed into research, which feed into updated guidelines, which then feed back into that clinical care. I mean, that is an amazing sort of amazing closed loop if it's done correctly. And that loop is getting shorter and shorter. But you think about the volume of information and the number of people trying to sort of undertake all of that, it becomes a really difficult thing to scale up. CPG ultimately is this amazing technology sort of powered by the the rest of the FHIR ecosystem, and ultimately really well served by a health information exchange built on FHIR that allows us to sort of digitally encode the best practice guidelines coming out of the various clinical societies and the research that are sort of powering their guidelines, and ultimately digitally encode them so that we can apply them either at the individual level, take a patient sitting in front of us and apply all of the most relevant and most current guidelines to sort of determine what is an appropriate next step in their care. And yeah, I guess even more interestingly than that, and especially because we're talking jurisdictional type systems like health information exchanges, apply them at population scale so that we can sort of glean what are the gaps in care, where are these clinical practice guidelines being applied well, where are they not being applied well, and most importantly, what action should we be taking to sort of make that come alive. That's one kind of example I find really interesting. Another one that I love to think about is the international patient summary community. I know in Australia, we're sort of calling it just the patient summary these days. And I think that's a trend that we're seeing increasingly around the world. IPS originally was sort of a summary of health information that was useful for unplanned care scenarios as we crossed international borders. And lots of people are still thinking about it that way. But I mean, these days, people are thinking about it for intra-jurisdiction workflows as well, which I think is a really interesting thing. Just the idea that if I had a simple summary of all of the relevant health information that was concise enough and portable enough that I could bring it with me or easily transfer it, there's just a wealth of use cases we can solve with something like that. A thing that I think was really neat, I guess, while I'm talking about more three-letter acronyms to go on all of these, people are often talking about pairing the IPS with another technology called Smart Health Links. Smart Health Links are effectively this little QR code technology that allows me to flash up a QR code and share one of these PS documents with a person of my choosing. What I think is really neat about this is it really is our first potential shot, and I say potential, we're certainly not there yet, but there's lots of people working on that problem. Certainly at Smile, we are working hard at this problem. It is our first potential shot at truly global health data portability and interoperability. This idea that I could flash a QR code, have any compliant EMR, and frankly, even if the EMR isn't compliant, there's sort of a fallback built into the protocol that allows us to show the summary through a browser. So anyone with a mobile phone with a camera could theoretically consume one of these things, even if they don't have any other specialized software on it. The thing that's really neat about this workflow is it's entirely patient-mediated. I, as a patient, have this incredible choice. Who I'm going to show the QR code, who I'm going to share it with. I can do that at home. I can do it when I'm on the road. I can do it if I'm in an unplanned care scenario across the world. I think it's utterly fascinating stuff.
It absolutely is. It's fascinating to this audience, indeed. And so for those that are worried that it's niche, I mean, this is the stuff that we talk about within the ecosystem, and to be able to cross those borders with that data. And actually, the point that really resonated with me then, James, was when you pointed out the analog transition that we're trying to make here of replicating what we've done in with new technologies. And I guess I liken it to when in a telehealth scenario as well. Often in a telehealth situation, people are thinking about how do we replicate the in-person consultation by just doing a consultation on a phone or hopefully on a video. But there's so much more that technology brings. So it feels like we're kind of progressing along that spectrum to be able to add more value to utilizing the technology to do what it can. If I think about all of that, if I was a health system and I'm looking at, okay, well, that sounds good, I want some of that. But then it becomes a little bit like, well, when there's everything that can be done, it's kind of like, it becomes overwhelming, and then it gets pushed down the line, and then we'll just keep doing what we're doing because we've got healthcare to do. If you were to help like a healthcare organization thinking about, look, I need to modernize how we approach this, and HIE sounds like something I should be getting across, and thinking about FHIR and having those discussions right up at a board level, where do you start? What are some kind of key bits that you think are like, okay, these are some parts that will really add value that can be then built upon?
Sure, yeah. So, I mean, if we're thinking about, I want to set out to build myself an HIE or, perhaps partner with someone to build one or something like that. I think there's a couple of key bits you'd want to think about, being, I don't know, key facets of that system,
Hmm.
or I don't know, key attributes of that system. Let's say that. The first, and I mean, I am a standards geek at heart, an open software geek at heart. So I make no bones about that. I will say, first and foremost, you want to look for openness, and of course, I'm a big FHIR advocate, so it's kind of obvious where I'm going with this. I mean, the HIE is, it's a platform for solving today's problems, and those are problems around data availability, of course. We recognize that making the right information available at the right time in the right place. I mean, that is one of the most important reasons for building one of these systems. But I mean, again, if all we've done with the system is replace faxes with digital faxes, I mean, we really have not moved the needle at all. If we're trying to build a modern HIE, we're making a big investment in a big old platform. And we want that platform to be something that's going to breed innovation for years to come. The thing needs to be a sort, for example, it needs to be a source of data that researchers are going to use to glean information from, to detect and understand sources of outbreaks, that type of thing. It needs to be a platform that's going to help incubate startups who've got ideas for the next generation of health tools to help people managing their own health. I mean, there's just all of these amazing uses for data well beyond just making that data available to clinicians. And I mean, of course, clinician availability. I mean, that is thing number one. I don't know about everybody else in the room here. The number of times in my own personal life, I've been sitting in front of my own clinicians, and they've used the regional HIE that exists in my own home of Toronto to pull up information about me. I mean, I know I've got better care from the systems that we have in place here, and I know that I'm going to get even better care through the new systems that are being built as we speak. So, I mean, nothing wrong with the initial making data available use cases, but these modern platforms built on open, embraceable, extendable standards, they're capable of so much more. So I think that's really interesting. Another critical facet I think we'd have to talk about is trust. I think we can all appreciate here. I mean, health data is, it's deeply personal stuff. It's kind of scary stuff if you think about it being digital, just because, it's such a ripe target for, I don't know, for people to be doing nefarious things. And I mean, I think it goes without saying that there's probably, a portion of the population in any given jurisdiction that probably don't realize these systems are being built and would probably be uncomfortable if they, as they start to realize that there are these great big digital warehouses being built of health data that is, potentially includes their own data. I think a really critical facet, therefore, of that trust is making sure that you have got appropriate security controls, and that those security controls, I mean, A, they exist, but B, they are simple and easy enough to sort of explain so that people can sort of get their heads around how is the system protecting them. And more importantly, that these systems are empowering people to make decisions about how their information is getting used and how their information is being shared. The FHIR geek in me here wants to talk a little bit about things like the consent framework that's built into FHIR and the audit framework that's built into FHIR. These are powerful tools, and I think anyone who's looking to build a modern HIE, the thing they'd want to do is spend some time thinking about, how is their platform taking advantage of the consent resource within FHIR, the consent tooling that exists in there, to allow people to make decisions about who their data is getting shared with, how that data gets shared, what purposes that data is getting shared for, those types of things. I think they equally want to understand, how is the system audited? How, as I think the gold standard in that case would be me as a patient having a portal I could log into to see who has actually looked at my data through the system. Where has my data gone? What's been done with it? How has it been used? I think things like that. I mean, if all of this is available, I think you've got a system that just instantly becomes vastly more trustworthy to people that maybe don't spend their lives thinking about HIEs, because I do recognize there's probably at least a segment of the population out there somewhere that don't spend their lives dreaming of FHIR standards and internet protocols and things like that.
Yeah. I'm sure it's a small population, but yeah.
Well, exactly. I probably not many of them listen to this podcast. Who knows? Maybe lots of them do. That's hard to say. I guess one last thing I'll say, I'm probably ranting a little bit, or I don't know, taking a long time here, but scalability, I think, is probably, I mean, in some ways, the most important one. you hear these stats constantly bounced around. Pushing healthcare aside for a second, you always hear people talk about just humanity generating more data exponentially every year than we did the year that came before it. I mean, that seems to be a trend that, it only ever gets faster. I have to assume at some point we're going to hit some physical limits to how much data we as humanity can produce. But I don't think that limit is coming anytime soon. And healthcare being a completely data-driven business, I think we can all accept that healthcare probably generates more data than lots of industries, and is probably going to accelerate even faster than lots of industries in terms of how much data it produces. So I say all of this just to say that if you're thinking about how you're going to build an HIE, really what you want to do is think about, am I building a system that is going to scale to what I believe are the amounts of data I'm going to produce in the next 5 years. And then you're probably going to think to yourself, I probably got that off by an order of magnitude. Am I building a system that could at least theoretically scale to orders of magnitude more data than I ever expected it to? Because let's be honest, that's probably what the future holds for this industry.
Yeah, that's wild to think about in itself, isn't it, too? The rate in which we're generating data and what that'll look like in 5, 10, 15, 20 years is, how do you get your head around that? I wanted to come back to that point around trust, because that's super important, because it's one thing for us who are deep in the weeds of it all in building, some of these solutions and in the health systems too. And if we get to the end of all that investment of time and money in building solutions, and then we go out to patients and say, hey, this thing is super secure and super usable, and someone gets it and they say, I don't know what to do with this, or this doesn't meet the need, then, we're not going to be able to use some of those things like the elements of the consent framework you mentioned, and bringing people along and making people feel like they're in ownership of their health data, wherever it's physically living or up in a cloud or wherever it might be. So that's interesting in itself. And I think that's a super important one to factor in that often gets thought about kind of later on. So thank you for that, James. I'm grateful that we've also got Angie here too, and appreciate you listening in on the context too from Farhoud and James, because I guess this is where the rubber hits the road, right? Like in terms of you and the Velatura Public Benefit Corporation, I'd love to learn a little bit more about some recent initiatives that you've implemented there that kind of tie into what we've talked about and what that actually looks like in the real world.
Yeah, sure. Well, and it's been great to get this context. In the U.S., we maybe a few years ahead of you in the sense that the network of connectivity has been built out for almost nearly 2 decades. But all to say, what James, I'm going to steal some of your thunder you created is it really comes down to the why, the how, and how much. Why are you doing it? How are you going to get it done? And how much is it going to cost not only to build it, but to maintain it? And so that's really where we are here in the U.S. is how we're taking health information exchange networks and the acts of health data sharing and health data interoperability and evolving it into what we're calling health data utility. So implementing a digital health infrastructure like a public utility. Post-COVID, when we didn't have what we needed, and even if we did, we didn't know how to coalesce it or analyze it and make it usable pieces of business health intelligence. Now we know better, and now what we need to do. And so transitioning or sort of upping our game, what I kind of like to call it, and making sure that we are centralizing data across the entire ecosystem of health data, inclusive of clinical data, claims data, patient-driven data, device data, other industry data from commercial partners, and obviously socioeconomic data, state agency data, public health data. You have to have an entity responsible to build out an infrastructure to support it, i.e. Smile, InterSmile, and other various partners for us, to be able to not only procure the data, but privacy, security, making sure you've got good data quality, because you don't want trash in, trash out when it comes to data. But then even if you deliver the data to their doorstep and it's a comprehensive clinical record or a comprehensive patient health record that's inclusive of all kinds of data, then what? Then what do you do with it? What is the patient going to do with it? How is it actually going to transform care? How is, from a healthcare business perspective, how are you going to pay for it to get delivered to you? How are you going to pay for the person who's going to then use the data to coordinate care differently, prescribe differently or follow up differently, coordinate whatever orchestration is required. How are you going to do different? How are you going to use the data either at a population level or at a patient level to make a better health outcome? And that's really where we're getting to now. The industry is demanding it. Like, we don't care that you can transact all this data. What do we do with it when we have it? And do we even have the personnel to be able to do something with it? So it's really not, it's as much an infrastructure issue as it is a workforce issue. And marrying those two things and those two challenges together is really where the interoperability industry has the most opportunity right now from our perspective.
Yeah, absolutely. It's that ongoing piece I think often gets overlooked too. You can build the thing, but then if you can't maintain, if you've not got the capability, and it, we're well familiar in healthcare in anywhere in the world, it's just because you can put in with a piece of hardware, just because you can put a new X-ray machine somewhere doesn't mean that there's going to be a lot of X-rays that come out of it. It'll sit there and bubble wrap for a long time. So I guess the same thing will be true within the data context too. So that's super important.
And it's also health equity, making sure that we deliver and make available health data interoperability solutions to every provider, regardless of how many patients drive their bottom line. And so, or which geography, urban or rural, that they reside. And so making sure we've got modernization available from a technology and from an interoperability perspective available across the provider ecosystem is critical to making sure we're comprehensive, making sure we are actually advancing, and then actually have complete data sets to be able to, do something with it when we have it.
Yeah, and I guess being super tight on being able to answer those fundamental questions that you put out there at the start will be super important in bringing everyone along for the ride, which is going to be critical. So that's important. Thank you for calling that out. I'm excited too, because it's always super valuable to be able to learn from people who are a little bit further ahead in terms of the journey. And on reflection, I'm sure that because any project that requires moving data around in healthcare is tricky at times, and there's going to be challenges that are faced. For those that are undertaking a project, what are some recommendations or I guess advice that you'd share to others that might be building a similar network of collaboration and data exchange?
Well, consensus building is the key to everything, from data governance to deciding your technology plan and roadmap, and then onboarding and what are you going to do with the data, and consent management and engagement, and then certainly funding strategies. So making sure that you are getting that consensus building by being seen, the HIEs or the health data utilities being seen as the neutral convener across competing industries and competing vendors and competing providers. And making sure that you sort of have that neutral, entity and ability to orchestrate, inability to get neutrality across just everybody working together. Everybody's going to pitch in a little to get a lot kind of thing. That's really the most critical role that you can play. And if you can get really successful at it, you can make things go faster. An example of that would be, in the United States, we have, some states have multiple HIEs. In the state where I am, Missouri, we have 4. And one of our success stories here in Missouri is that all 4 HIEs were able to come together and roadmap a plan to our state Medicaid agency to get our health information exchanges funded at a $50 million annual appropriation to be able to drive use cases through the HIE to become a health data utility. And all of them are focused around public health and Medicaid beneficiaries who receive, their health care through the government. So it is a critical piece to be able to say, hey, you can get all of those entities to come together and divvy up the work and divvy up the responsibility and have a shared governance and still be driving towards the same lane. So there's multiple examples of that are happening. But that's how you progress, and success breeds success that way. So it's critical to the future, especially when it's so competitive. I mean, this healthcare is very competitive when you think about all the vendors in this space. But if we can get to a place where we could say everybody gets a little bit of the pie, nobody gets the whole pie, it's a better spot for us all.
Yeah, absolutely. It's there's that. It's important that we see these examples of partnership and collaboration and mutual objectives. And I think if we can all come along that journey, that'll be important. And you gave us a glimpse of that future there, Angie. And I picture a world where I can, as a patient, rock up to any clinic in any part of the world and whip out my phone, like James said, and get my information up ready. Or the clinician on the clinician side has access to everything. And none of the data ever leaves where it needs to, and everything is safe. And we all sing Kumbaya. They're probably still not going to solve all the problems, but it is something that we're working to. I'd love to get from your perspectives, each of you, on what excites you about the future of this space, because there's a lot of passion, a lot of alignment, I feel, sometimes in terms of where we want to go with this thing, but there's still a lot of stuff to do and challenges to face. What excites you about this connected care space and how it's evolving, Angie? And then I'll go to James and then Farhoud.
Well, I think the consumer will drive this business in the future. Consumerism and AI are going to drive where we're headed and drive us there the fastest. To your example, and James is like, yeah, we all want it right here on our device, and why not? Like, when I talk to patients, they're like, wait, what? That's not already happening? Like, why can't I have this? It's already an expectation. And so we've got to meet that expectation. And we've got to have strategies to invite the consumer to be a part of it and be proactive in driving us there. But a lot of it, especially in the US, is policy and technology are not in balance right now. Policy is sort of more archaic and not modernized when it comes to provisions of data sharing and when you can and can't and who you can't with. Typically a common example is your health data should be as portable and transferable as your financial data. They're both equally sensitive. But in the financial industry in the US, it's shared with everyone without some of your consent, depending on what services and tools you're trying to buy or purchase or use or leverage. And so we don't have that kind of policy parity. And so policy and consent management is very key. And I think AI is going to be the most helpful tool in getting us over that hump in the future, is being able to how we can start to, get the patient more driven to, through their devices, be able to consent faster to data sharing.
Yeah, no, I agree. And kudos to us for not mentioning AI for 35 minutes.
No kidding.
You're the first.
Incredible. Let's talk about blockchain next.
James, what about you? Your vision for the future?
Sure. Well, let's be cheesy for a second. What's the old saying? Inside you there are three wolves. So let's say that the geek wolf inside James is just so amped up for sort of the signal processing innovation that'll come. I was talking before about sort of this idea of the structured, well-structured data flowing through the HIE. And I mean, I think this is nothing short of a revolution. I mean, those of us who've been working in the trenches of the HealthTech space for years, and I'm sure many of your listeners are similar like that. We've been fighting for years for just simple, well-structured, available, well-coded data to be available so that we could move on from that, move on to solving more interesting problems. I think Fire doesn't solve that problem on its own, but it really has moved the needle. It has sort of brought up the level of availability of good, well-structured data. Certainly we have to give shout-outs to organizations like SNOMED and Loink, and obviously the AI revolution is doing its part as well. But the point is, we've got data. We can start doing really cool, geeky things with it. I'm super excited about that. The entrepreneur wolf in James just loves this democratization of APIs and data that's sort of coming out. I don't know. I suppose that builds a little bit on the previous point, but I think there's a world opening up right now to entrepreneurs to start building fascinating new systems. And I mean, all this stuff is just great for that. I think it's a great time to be an entrepreneur in the health tech space. I have to believe that's true. Finally, and most importantly, the patient wolf inside James. I mean, we are all patients at heart. We know that. We've all got families that are part of the health system. We've all sat in front of doctors ourselves. We'll probably spend more time sitting in front of doctors as we get older. And I mean, just this future where I theoretically, I'm in that example of being able to flash a phone. That's one of them. But just the ability for me to participate in my own healthcare through better access to information, potentially better ability to contribute to that wealth of information about me. I mean, there's just so much sort of possibility still to come. I love Angie sort of terming this as a utility. I mean, ultimately, that's exactly what this is. I'm sure in the early days of electricity being available in houses, there were lots of people who thought, why are we investing in this? Why do we have all these ugly wires around everywhere? Like, why are we doing any of this stuff? It's dangerous. Why would we do it? I mean, you can make all those, and I'm sure people do make all those same arguments against investment here. But I do fully believe that, if we can fast forward 10 years from now, it's going to be as obvious why we need this infrastructure as it is today, why we need electricity in our houses. I mean, it is rapidly becoming an indispensable part of the experience and the delivery of healthcare. So there we go. We'll all be better off as patients, I'm sure, for it.
I love that comparison, and I've not heard that one. So that's a great way to think about it. And Farhoud, bring it back to the yours and my home turf in Australia. Energized about thinking about the future of this space. How can we apply it to our context here?
Thanks, Pete. So I'm going to go back about 15, 16 years ago. I was working in New South Wales Health, and I'm sure the colleague I'm about to talk about is probably listening to this podcast because he's one of that 1% that's still in this domain. He turned around and said, wouldn't it be great if we all had avatars of ourselves in the healthcare system where we could actually apply to our journey? I looked at him funny. I couldn't understand what he was talking about, Pete. That'll never happen with fax machines. But if you sort of fast forward to now, maybe 10, 15 years from now, and some of the technology that James was talking about as well, right? If we get the data right, if we code it properly, if we store it properly, if we share it properly using standards like FHIR, and then overlaying that with some of the genomic data sets that are coming out. So when James goes, the data is growing at this rate, it's going to exponentially grow over the next couple of years. Add omics over the top to give you that personalized flavor. And then overlay that again with your IoT or medical IoT devices like your watches to be able to then bring all that real-time data set over your own personalized data set. And then taking it to Angie's conversation about AI, even though we spent 35 minutes not talking about it, bringing AI over the top of that and some of the analytics that James was talking about on top of that open standard, because now you have coded, clean data sets that you can apply models utilizing all the historic healthcare learnings. Then you get to precision proactive medicine that's personalized to you, right? And then you can then apply that to your digital twins, which is your avatar, right? It's not my idea. It was someone else's 15, 16 years ago and probably 20 years before that. But why are we there now, right? Why is it so important? Where are we at? I think some of the initiatives we've got going in Australia around the Spark Fire Accelerator that is pushing us to standardize on some of these technologies and sort of get those standards open. The investments that the federal government's doing in the My Health Record modernisation to enable that data sharing and data exchange. I think we're at the point where we can actually lay these foundations in the right way, that we might all have an avatar that follows us around that enables us to actually see what the impact of, taking a particular drug might have on our personal healthcare before we even take it, to be a bit more proactive and personalised and then engage with our own virtual self. Apple's AR, VR headsets might even enable us to even look at ourselves, 3, 4, 5 days ahead of time and try to sort of understand what does me doing something today mean to me tomorrow, right? So I think there's a lot there in that future healthcare being a bit more personalised and proactive, but it really, really then depends on some of these foundational elements that we need to set today to make it happen. So it's not my idea, Pete. It's someone else's. I stole it. I hope he's listening. And sees that I didn't take credit for it, but that's a bold vision to have.
Yeah, and I love that too. In that we by getting these foundations right, getting the fundamentals, we can do as James I think suggested too. Is that if we enable a lot of the entrepreneurial thinkers or even the larger organisations that have access to be able to do things at scale to even think beyond where our headspace is at right now. There's a lot of exciting stuff to look forward to. We've got to get those first bits right, and it's cool that we've got some energetic people that are passionate to do it. I love as well that we're just scratching the surface on these types of topics, and I know we'll be continuing on this little mini series on future episodes of the Talking HealthTech podcast, where we can look at some clinical use cases and some local examples here in Australia, and some care gaps and how research plays a part too, which I know we only just touched on in this conversation. So we'll dive into that in future episodes. So stay subscribed so you can check those out. But in the meantime, Farhoud, Angie, and James, thank you so much for your time.
Thank you.
Thank you.
Pleasure.
We hope you enjoyed this episode of Talking Health Tech. Make sure you like and subscribe and share this episode with someone who might find it valuable. For more information and resources about healthcare innovation, visit talkinghealthtech.com.